Hi, my name is Katelynn Boerner, and I'm really pleased to share this video abstract of our paper looking at family perspectives on in-home data collection for children who function across the developmental spectrum. I'd like to start by acknowledging that I live, work, and am speaking to you today from the traditional, ancestral, and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh nations. The COVID-19 pandemic, the rapidly developing availability of technology to support remote research data collection, and the increased focus on the intersection of social justice and health have highlighted the urgency to develop more accessible ways of conducting child health research. Together with my co-authors, we've begun to develop the concept of a living lab at home, a way of bringing child developmental, behavioral, and health research into the community. To do this, we needed to identify methods that would allow us to move from traditional research protocols towards ambulatory, dynamic, real-time, micro-longitudinal data collection that happens where families live. We wanted this to be co-developed with children and families and accessible across the developmental spectrum, as well as integrating multiple modalities. So we chose to focus on 3 modalities to start. The first is Ecological Momentary Assessment, or EMA, which is questionnaires of symptoms, contexts, and emotions conducted on a smartphone multiple times a day over multiple days. Actigraphy, which provides measurements of physical activity and sleep via a wearable. And salivary cortisol measurements of biological stress response. This concept of collecting data in the community is not novel, but the application to the developmental spectrum and the integration of multiple modalities might be an opportunity for innovation. So we recruited families who spoke sufficient English to be interviewed and who represented 2 groups. The first was youth and/or their parents who were recruited from autism, cerebral palsy, and complex pain clinics. And the second was a group of families with a child with severe neurologic impairment. After providing consent and assent, families took part in a semi-structured interview that was conducted over Zoom, where we asked about their perceptions on in-home research. The interview format was adapted for the needs of different families. Following the interview, they were transcribed, and then we analyzed the transcripts using reflexive thematic analysis and descriptive statistics. The families that took part in our study represented a wide range of experiences and diagnoses. This table presents the coded responses to the quantifiable questions asked during the interview. In general, most families would be willing to take part in a living lab at home study, and if there was a specific method that they would not want to participate in, it would be the accelerometer or saliva collection. This was mostly related to concerns about the look or feel of the accelerometer or concerns about the privacy of biological samples or activity tracking. Most families felt that they could do this method of data collection for 2 weeks and would prefer that this be continuous without a break. And most wanted access to their data in some form, either their individual results or in aggregate. From our qualitative analysis, we identified 3 key themes from the data regarding what aspects of participation in in-home child health research were important to families. The first theme was around flexibility, and families talked about the need for flexibility in terms of timing and being able to pause data collection, the involvement of different caregivers, the sensory look or feel of methods, and considering taking a trauma-informed approach in thinking about how being prompted to participate in research multiple times a day might be a reminder of families' challenges. Families also talked about wanting a reciprocal relationship with the research team where they wanted to benefit from research, but not necessarily always in the form of monetary compensation. Families talked about wanting to access their own data from research to be able to better understand their condition, track interventions, and increase accountability, communicate with care providers, and identify care goals. And finally, families saw the potential to increase their opportunities to both contribute to health research, as well as benefit from seeing their child and others like their child represented in health research thanks to more accessible methods. This would overcome financial, logistical, geographic, or mental health barriers by being able to take part in research in the home. And families described the ways in which this approach could reduce confounding effects of being in an unfamiliar or an anxiety-provoking environment. So finally, to summarize, these 3 themes that families identified really illustrates the importance of participant co-design in methods. Families identified many potential benefits and also generated solutions to potential challenges or adverse events. And in our future research, we plan to look more closely at other important equity-related variables such as socioeconomic status or geographic location, and to consider how our research methods can be most accessible to all. Our next steps include incorporating the results into pilot demonstration projects to test the feasibility of these methods using all of the adaptations that families talked about in their interviews. And I'd like to end by thanking our funding sources and also by inviting you to read the manuscript to learn more.